Good evening, everybody. Welcome to this another session of 50-second comprehensive course on echocardiography. I'm Dr. Rakesh Gupta with my team over here in Job Institute of Echo. And I'll request everybody, please silent your mic. Or may I request anybody who want to talk, please go out of this program now and let's not waste time on other people. So with me, I have my colleague, Dr. Mrs. Reena Dua, along with two of my professional partners, and this is Mr. Shrikant and Ranjay, who's trying to demonstrate you all the screens. Look, what you have seen on the screen right now, I'm trying to focus one by one button, each of them. If I press this button 2D, here is the button 2D. If I press my button 2D, I straightway get into my image of 2-dimensional cycle. If I switch on my colors, there's a button with the name of colors, and look, the color box has appeared. And how do you optimize your color gains? I'm increasing my color gain scale. Look, I'm increasing my color gain scale. Not scale. This is Nyquist limit. I'm increasing my active mode. And look, a lot of colors will come into it. So I'll reduce my color till this color disappears. Now I'm optimized for my colors. Whenever we need to do a pulse oximeter, pulse Doppler, we go to cursor. Look, there's a word named as cursor. So as soon as you put a cursor, you can see a line which is in the color box. And once the line is in a color box, I go to pulse wave. Look, here's a pulse wave. I press pulse wave. Same thing. And look carefully in this pulse wave there are two boxes are there in this pulse wave. If I switch on to continuous wave Doppler, it becomes a single box. Okay. So these buttons are right on your screen. That is 2 dimensions, M mode, right over here, M mode. Then color, then CW.
Then buttons are not visible.
Look at your second screen, man. I can't stop for you now. And I'm back to 2 dimensions, 2D. Then there's a word which is known as freeze. As soon as I press a freeze over here, it will freeze automatically. There's a word caliper seen over here. So press caliper, you will be able to see everything measurements. And if you want to go to measurement, look at the right side of the screen. I'm look on the right side, you can see all the measurements on top of this. Now you can see all the measurements over here. So these are all Knobology which I'll be using over a period of time for demonstrations. Now I'm going straightway to my color Doppler and I'll show my hands movement from moving away from my knobs. Here is the subject. If you look at this subject, he has got ECG gating. One on the left shoulder, right shoulder, and third on the right hip. With this ECG gating, I'm able to show you like this is running an ECG and we can increase the gains of this ECG. Now look, the heart rate of this particular person is 82, 83 beats per minute. Second comes the transducer. Look at this transducer over here. Can you see the transducer? Right. This is the footprint of a transducer. This is the mark of a transducer, index marker, and other side there's a one dot is there. So you have to look at your screen, which is the index marker. Look at the probe. Where is the index marker? Where is the probe? And important thing is, look at the right side of your screen is the word V is written. If this is V, this is a correct formation of the imaging quality. Now look at the chest wall. This is sternal angle. This is second intercostal space. This is third intercostal space. This is second and third intercostal space. My index marker at 11 o'clock position. So I'm keeping my index marker at 11 o'clock position. Look, my 11 o'clock position, the index marker is. As soon as I keep at 11 o'clock index marker is, I start seeing my window. Look, I'm holding my probe with the other hand. You can see the index marker. Right side is 11 o'clock position. This is 6. This is 3. This is 3. And this is 12 o'clock position. The index marker is facing at 11 o'clock position. Is that correct? And once the index marker at 11 o'clock position is, I'll just freeze this image. This is my touch point, RV free wall, RA, anterior aortic root, posterior aortic root, aortic valve. Anterior aortic root is in continuation with interventricular septum. Posterior aortic root is in continuation with AML. This is LA. LA free wall is in continuation with PML and posterior wall. So we have RV, aorta, LA, and LV. This is basal interseptum. This is mid anterior septum. This is basal posterior wall. This is mid posterior wall. Is that okay? Now look at the depth of this patient. Here is the depth. This is starting from here, from this point, and this depth is almost 15 centimeters. Now, this is Plaque's view. From Plaque's view, I'm asking the footprint looks towards mediastinum. So the footprint is looking towards mediastinum. Correct? Here is a Plaque's view. Footprint looking towards mediastinum. A little tilt of the footprints towards the mediastinum, that will give you RV, RA inflow V. Here is the RV, RA inflow V. I'll increase the gains so you can see the tricuspid valve leaflet. Here is a tricuspid valve leaflet. I'll go back again. Plaque's window, RV, RA inflow V. I'll come back again. Now, same patients, I'm rotating my probe 90 degrees. Look, I'm rotating my probe 90 degrees. And my footprint is looking towards aorta. At the same point, this is mitral valve. Left third intercostal space, we have the mitral valve. And what do we see in mitral valve is? We see AML, PML, lateral commission, medial commission. Now for mitral valve, my footprint is looking towards aorta. So here is aorta. The parasite short axis movement aorta will come automatically. Now I'm going back, mitral valve, then towards left hip, and finally the apex. So there are total 6 views. Plaques, RVR inflow view, back, rotate 90 degree. You will get mitral valve, aorta, mitral valve, papillary muscles, and apex. From this window, we go to apical window. I'm at fifth intercostal space, and almost at mid-axillary line. My index marker is at 3 o'clock position, 2 to 3, depending from patient to patient. I can look at my 4-chamber view. This is my LV, LA, RA, RV. Now look, I'm rotating my probe 90 degrees. 2-chamber view comes up. I'm further rotating it, the 3-chamber view comes up. So at 3 o'clock position, index marker as parallel to the heart as possible. Rotate 90 degrees, 2-chamber, rotate further, it becomes 3-chamber. Look, this is like Plaque's window in erect positions. So from here, if I go back and slide to my Plaque's window over here, I'll get the same view. So in case you get a difficulty of making a apical window, slide from Plaque's view, go all the way to the 3-chamber view, rotate clockwise, 2-chamber view, rotate further clockwise, 4-chamber view. Now let the footprint looks towards aorta. The 5th chamber aorta opens up. This is a blue color. The aorta opens up. Correct? Third view is, let him lie down flat on his back, see the leg jump. Legs folding. Suprasternal window, subcostal window, 3 o'clock position. Subcostal window, 3 o'clock position. You see an RV free wall, RA, RV, and counterclockwise rotation will show you the IVC. Here is IVC. Here is LA, LV, LA, RV, RA. Counterclockwise rotation will show you IVC. Look, IVC is very small in size. It means his volume deficit. Then next window is suprasternal window. Index marker at 1 o'clock position. And in case you can't find it, switch on colors. Now you can see a descending aorta. Negative Doppler shift. Is that correct? So you could see all knots. You can see all views. Any questions by now? Can you raise your hands if any questions are there? Now, hello. There was no question in your voice.
Sir, that suprasternal window, 1 o'clock or like
1 o'clock.
okay.
So,
Sir, kindly show me once the right ventricular inflow and right ventricular outflow, please.
Index marker facing towards mediastinum. From Plaque's view,
sir. And sir, right ventricular outflow view, how can we get that?
The right ventricular outflow view is parasternal short axis view at aortic valve. P-sacs at aortic valve.
Sir, kindly demonstrate me once.
Short axis view at aorta. So I taught
Okay,
you
okay,
about
okay, sir.
mitral valve. And this is outflow. So if you look at this is inflow. This is RVOT. This is proximal RVOT. This is distal RVOT. And from here, the pulmonic artery bifurcates to right and left. Voice recognition.
Okay, sir.
See the picture? Turn on the other side. Neck turn to left hand side. Index marker at 1 o'clock position. Just put in a suprasellar window very carefully. Don't press too much because just right over the trachea. And as soon as you see a suprasellar window, here is the descending aorta. Majority of time you will not be able to see a descending aorta very easily. Then switch on the colors. Now you can see the descending aorta with the colors. Correct?
Okay, sir.
This all comes with the practice. As much you will do the practice, things will move automatically with you. So anybody, any other questions before I move to the next part? I know it's
सर
a
एक बार
difficult.
नोबोलॉजी एक बार बता दीजिए सर दोबारा प्लीज.
In this knobology, the screen sorry. Now every machine has got this setup. There is a word 2D. As soon as you press 2D, the machine will automatically go into 2D mode. Then after 2D, there's a word known as M mode. So switch continuous M mode. If I press a button, it will go to M mode. And the cursor is moving. On top, you see a cursor is moving. Then switch off M mode, press color Doppler, the box will appear. Then reduce, this is movement of the box. And in this machine, in this knob, you can press and you can reduce the size of this box and elongated it by scrolling the machine. And smaller the box will give you a high frame rate. So a machine should have at least 50 frame rates once you are doing a color Doppler echo. After this box, there's a word knob is there with the name of cursor. So as soon as I press my word button cursor, it shows left and right movements, and this is up and down movements. If I say pulse wave Doppler, this cursor will become show a two box structure, and this will demonstrate about a flow at the site specific flow. If I press my button CW, it will convert to a continuous wave Doppler, and look, the box has disappeared in the cursor and it becomes single line. Back to 2D. Now there's a word caliper. Whenever I want to measure something, I can just straightly go to the caliper to measure it. Switch off caliper, then there's a word known as measurements. Look, right side, all measurements appears which you can measure. This is what the knobology is. Majority of time, this is the knobology, and this is a freeze button. An image will freeze. Now you want to acquire the images. There's an image store. Now I've set my machine in such a fashion that I will see what I'm seeing. I'll store only before than that, I'll see that system. Look, I'm doing this. I'm recording these images. I'm recording this image and I press the button freeze. Put it in the house, freeze. Now this image is moving continuously, and look at this is the one loop I have acquired. I can make it 3 loops. 1, 2, 3. Now I've acquired 3 loops. I can store these 3 loops now. Answer is I can get back these views without acquisitions. Now I can see and analyze these 3 loops at any time. That's what majority of knobology is. And for learners, I always say these words. Once you sit on a machine, you must look at every button. Press and see what's happening to the button. In that case, you'll be able to do very good things. Because the best part of the system is, once you switch off, they go back to the normal factory settings. All right. So let me move to the next part, which is known as color Doppler. If I happen to see a flow, the flow which is towards a transducer, which is almost what? Red in color. If the flow is away from a transducer, it is blue in color. So we'll look at the screen. Meanwhile, my subject has gone to the toilet. Let me show you the recorded images. कैरविन बनी हुई है बट नहीं बनी हुई है देखो कब उठा ले बेटा तेरे लिए भी बनी हुई है Look, this is parasternal short axis view at aorta. This is pulmonic valve, this is aorta. This is pulmonic artery. Pulmonic artery bifurcates to left, right, and left. And this is descending aorta. Now you see a reverse flow from descending aorta to pulmonic artery. What is that?
PDA.
Perfect. It's a PDA. And this is descending aorta flow. Now I freeze this flow and look at carefully. This flow is happening during diastole or systole. So look at the ECG gating. I'm at beginning of systole. So at beginning of systole, I'm hardly getting any flow. During diastole, I'm getting a whole reversal of flow. Why is that? Because aortic pressures are more than pulmonic artery pressures. In systole, I'm still getting a normal flow. I don't see any reversal. If I happen to see a reversal in systole, it means pulmonic artery pressures are more than systemic pressures. What is the flow color direction? No, it's red. It's a mosaic red color. So it's a transducer. Look at my screen over here. This is Nyquist limit. It starts with red and gradually becomes yellow. It starts with blue, gradually becomes sky blue. So you must have remembered your old physics. Violet, indigo, blue, yellow, orange, red. Vibgyo. Violet, indigo, blue, green, yellow, orange, red. So violet, indigo, blue, green, yellow, orange, red. So I can change this baseline. Normally we keep these colors at a Nyquist limit of 60. Correct? So the subject has come. Let me show him the flash window. Now I'm going to the flash window again. Remember, whenever we do 2 dimensions echo, it should be perpendicular. Whenever we do a Doppler, it should be parallel. Now, if I switch on my colors, look, what do we see over here? With opening of mitral valve, you can see a red color. This red color is going from LA to LV. The direction is up towards the transducer. It is red. Same patient, if I go to systole, the direction becomes blue. Why the direction becomes blue? The blood is going from LV to aorta. Red towards blue away. Blue away, red towards, that is known as BART, B-A-R-T. And do we measure any flow in this? We don't measure any flow in this because we are almost perpendicular to the flow. Angle of interrogation should not be more than 20 degrees. Now my angle of interrogation over here, my cursor will come from this place. Let me just show you the cursor. My cursor is over here. So at what angle I am demonstrating? This is the angle. This is one angle. This is second angle. So I'm almost at 90-degree angle. If not 90, more than that. So if I measure my color flow over here, I'll be underestimating it. Only one flow which we can measure is once we go to inflow view, RV-RA inflow view. Now look in RV-RA inflow view. I'm as parallel to the blood flow as possible. Look, my line is almost parallel to the blood flow. So this is one of the window for measuring what? Tricuspid flow regurgitation or tricuspid inflow. One take-home message. Now go to short axis view at aorta. Many things are seen over here in the aorta is the most important is the flow in the aorta, this pulmonic artery. So here is a flow in pulmonic, this pulmonic valve. You put your sample volume, pulse wave in this pulmonic valve. So this is RV-OT flow. Because we are before the pulmonic valve into RV-OT. Okay? If I want to see a continuous wave Doppler, two lines have become single lines. This is a flow across pulmonic valve as well as RV-OT. So this is a flow across all this line of interrogation. I want to see distal pulmonic artery flow. So I'll go to left pulmonic artery flow into the pulmonic artery, left pulmonic artery. If I go to the right pulmonic artery, it will be right pulmonic artery. So pulse wave is site specific. Now this Doppler flow is below the baseline. So this flow is away, negative Doppler shift. So we see pulmonic flow, pulmonic stenosis always in this view. Here is tricuspid flow, second window. So I need to look at a TRZ. I'm going to keep my window over here, put a continuous wave Doppler to get a TRZ velocity. TR would be systolic velocity. So passive short axis view at aorta, and this is the first window where we measure pulmonic flow. We cannot see pulmonic flow in anywhere else at level 1. But we have seen two tricuspid flow over here. From this window, I will go to the apical window. Now, in fourth chamber view gives me a lot of information. What information it just give me? It gives me mitral flow pattern. Now, I'm freezing it. This is my mitral inflow pattern. Red color. And this is my aorta. I said footprint looking toward aorta. My aortic flow is away. So this is mitral flow. This is aortic flow. And then from here, I go to focused RBRNE. So I'm focused tricuspid view, third window. So this was third window. Focused RBRNE view is the fourth window. And I keep my sample volume always distal to the tip of the leaflets. This is tricuspid flow. I can measure this tricuspid flow. This is E wave. This is A wave. Normal flow is 50% of mitral flow. Mitral flow is 1.3, 63, 65. Look at the flow here is only 43. Normal tricuspid flow. From this fourth chamber, I'll go to 2 chamber, then go to 3 chamber. I can see another Doppler flow in this 3 chamber of aortic valve. So aortic flow is seen in 5 chamber and now in 3 chamber. If I keep my sample volume into the aorta, distal to the aortic valve leaflet, it will be aortic flow. If I keep my sample volume before the aortic valve, it will be LVOT flow. So let's measure LVOT flow. This is 12.97 centimeters. This is little underestimated. Normally is up to 24. So when we calculate stroke volume, what we need is LVOT VTI. So look, the LVOT VTI over here is 12.97. And second factor, what we need in this LVOT stroke flow is LVOT dia. So here is LVOT diameter, 20.1 millimeters. So once you have a dia, when you have a VTI, you can calculate the stroke volume. Now, in this particular fashion, same patient, we get the VTI, we get peak velocity, we get mean velocity, and we get peak gradient, mean gradient. So I'm going to show you all these things together, which is applicable everywhere. So I'm going to keep a sample volume, continuous wave Doppler. That was artificial intelligence. It will automatically trace. But this is how I'm going to trace E wave, A wave, bring it to bottom, enter, then heart rate. Now, once I trace this Doppler spectral pattern, this will give you what? It has given me peak velocity, mean velocity, peak gradient, mean gradient, velocity time integral, and a heart rate. And this box, look, this box is full, suggesting that this is calculating velocity from this point of interrogation to this point of interrogation. Continuous wave Dopplers. And we can calculate pressure half time. So I'm going to calculate pressure half time from this point to this point, pressure half time. Give me an area of 1.65 centimeters square. Somebody want to know. Is that clear? Same subject. If I switch on my colors, now this is pulse wave. Now what exactly it's doing? It is doing the same thing, but it is only measuring a flow velocity across this mitral valve. Now I'm going to do a trace of this. Not perfect. So I'm going to do a trace manually. Now same thing, 0.58, peak velocity, mean velocity, peak gradient, mean gradient, velocity time integral, and a heart rate. Whenever we have a stenotic lesion, when we say stenotic lesion is, when by my pulse wave Doppler, my velocity is more than 1.3 meters per second in mitral valve, more than 1.7 meters in aortic valve, then I switch over to continuous wave Doppler and calculate peak and mean gradients. Same subject. I'm going to calculate TR jet velocity now. Now focused RBRNU. I've moved to fourth intercostal space, focusing on my tricuspid valves. And calculate the tricuspid revegetation check. Now, little bit not a good imaging quality because it does not have a significant tricuspid revegetation check. So this is the TR jet velocity, 2.3, gradient of 21 millimeters of mercury. Look, I'm able to see the Doppler spectrum pattern in this subject. This is coming from here. This is peak and going back. And this is systolic. Look, ECG is telling you this is systolic. Correct? So that's how we look at Dopplers, which gives you peak velocity, mean velocity, velocity time integral, and gradients. See the later? Very important thing is IVC size. So counterclockwise rotation is still IVC is small. You should drink some more water. And I put my cursor line distal to the hepatic vein, just distal to the hepatic vein. Look, his IVC is very small. I can measure this IVC over here. 0.52 and its collapse is almost 100%. Shabbos. So anything less than 13 millimeter is considered as less than 1.3 centimeter. Less than that is considered as volume deficit. So questions in colors. Raise your hands. I know it's a tough, not a tough thing. Any questions? Dr.
Sir.
Rajan Varghese. I can remember you, Rajan. I can see everybody now. Go ahead,
Sir,
Rajan.
can we repeat IVC?
IVC.
IVC measurement, sir.
Right, done.
Sir,
Wait a minute. Just a minute. Just raise your hand. I'll call your names. Counterclockwise rotation, IVC. Look, this is all IVC is. Very small. Be careful. Behind the IVC, there is aorta. This is IVC. Counterclockwise rotation, very small, subtle counterclockwise rotation. And if you can't see IVC over here, udhar ghum jao. Just let the patient turn on left hand side. We can keep your probe over here. If I can see hepatic veins. So I'll try to look at my heart shadow first. See my heart shadow. So here is my IVC. This is my IVC over here. This is my heart. This is my IVC. So I can look at my IVC here also. The more you do, the more you will learn. It all depends on your expertise. This is all hepatic veins. At the same time, you can see a portal veins also. These are all hepatic veins. Veins into IVC. Now they're away. Now they're draining into IVC. Now you can see the IVC. Very small. You can open it now. I'll try to open up the log access. Number 20, question. Shabir, your question.
Sir, good evening, sir.
Good
So I
evening.
have two questions, sir. One is, sir, in very obese patients and in female patients, I'm finding it difficult to get the optimal view. Can I do something, some adjustment so that I can get a good view, sir? This is my
In
first.
female patients, let's use somebody's sister. Ask the sister to let the patient take a turn on the left hand side. Help
Okay,
sister raise the breast tissue
okay, sir.
and then go behind the breast tissue.
Okay,
You should be in anterior or mid axillary line always.
okay, sir.
And second, in obese patients, I know you get to your lowest possible imaging quality transducer frequency, like 1.5 megahertz transducer frequency.
Okay, sir. Okay, sir.
Dr. Gaurav, 23 and then 40.
Thank you, sir.
Good evening, sir. Sir, my question is, sir, when you have done that TR tracing of the subject, how you change tracing graph to gray background as it was more easily visible?
There's
So
a
how
word
you?
which is known as color map on the screens.
Okay, sir.
Look at this, I'm showing you a picture. Can you show this? Look, this is a whole touch screen. I'm going to focus on word which is known as light, color maps. And now the screen has popped up another things on a screen. I say not changing colors. Correct?
Okay, sir. Right, sir.
So look at the color map on right side of a screen. You can change any
Okay, sir.
color you feel like. All right?
Okay, sir. Okay. Thank you,
All
sir.
right. Next person. Dr. Ajay Chaurasia.
Sir, it is quite matlab easier for us to get that plaques and apical views, but when it comes to subcostal, now we don't get the directions well, and at the same time, many of the times I don't get the chambers only. So how to exactly approach it? That is little I am finding difficult.
I'll show it again. Let the subject lie down flat. See the rato? सबसे बड़ा important चीज क्या होता है कि we don't let the patient lie down flat. Let him fold the legs. Look at him folded the legs. Let him relax his abdomen. Face the subxiphoid process and put your probe just near the subxiphoid process. I'll show you that. Now, this is my subxiphoid process. And probe is right in the subxiphoid process.
Okay.
If you can't see a window, ask the subject to take a deep breath and hold it. Lamba saans do. Now look, he's coming closer to you.
Oh,
आपने अल्ट्रासाउंड में सुना है जो डॉक्टर्स बोलते हैं पेट फुलाओ. Let the person take a deep breath. Look, everything. Hold on. Roko. Now everything comes in front of you.
yes, yes, sir, yes.
And your probe tip should be slightly towards right hand side. Because you're not focusing on LVLA. You're focusing on RBR.
Yeah.
Then slight counterclockwise rotation, now your IVC is opened up. Is that clear?
Okay, yes, sir, yes, sir, yes, sir.
Like tilt of a steering of a car.
So almost from 3 o'clock to 2 o'clock position, something like that, and
Slightly left turn.
okay.
Just a little turn. When you bend your car either to left or right, you don't turn 100% 90 degree, 110 degree. You just bend a little bit.
Okay, okay.
Got it?
Yes, sir.
All right.
Another thing is, if we are doing these views and if we put a freeze, so if I have to go back to see systole or diastole, something like that, so we have to
Scroll.
just
Scroll.
from freeze, we have to just go back and we can see whatever we have.
Yes, you can. Look, I'm
Okay.
doing everything in front of you.
Yes, sir.
With a trackball, you can freeze and scroll.
Okay.
And
Okay.
that's why I said, once you start doing a practice, always use ECG gating.
Okay.
Connect electrodes.
Yes, sir. Yes, sir.
All right, I'll show you one more thing why you need to connect electrodes. I'm saying these things again and again. Harmonic flow has got two flows, systole and diastole.
Yep.
Correct. Now I'm going to switch off my ECG first. Now my ECG is gone.
Hmm.
I'm switching on my pulmonic flows now. I'm into the pulmonic vein. Okay. Let me show you a recorded finding. I just did it today in the evening. Give me a second. All right. This is, let me just see if I can get rid of this ECG gating. Right. Now, away from the ECG gating, tell me which one is systole, which one is diastole. Same patient, I show you ECG gating. So this is systolic, this is diastolic flow. This is systolic flow, this is diastolic flow pulmonic, left pulmonic vein. So you need to have ECG gating all the times.
Okay.
It'll tell you heart rate. It'll tell you so many things. Look, this is PDA flow. So the PDA flow is distinctly during diastole, not during systole. If this PDA flow would have been during systole also, it means what? It means RV systolic pressure is more than. No. It means what? It means the RV systolic pressure is also more than systolic pressure of pulmonic artery. There's something high pressures over here. The right pulmonic artery pressures are very high. Because PDA is a constant phenomenon. It's not this isolated diastolic phenomenon. So it's a lot of mathematics which is used in this evaluations. Dr. Debanjana.
Good evening, sir.
Good evening, Debanjana.
Sir, I just wanted to know how far into the, how far away from the valve are we going to place the cursor?
Just distal to the valve leaflet.
Okay.
Let me just show you. Here I'll keep the cursor.
Okay, sir. Understood.
Dr. Anirbar Singh.
Sir, while placing the probe in the transhepatic position, so what should be the landmark? So is there any landmark?
What is transhepatic
And
position? I'm not able to understand what is transhepatic
so
position.
so like that, while say, when viewing the IVC, one is the subcostal, and then you can show that there is another position like moving the patient to the left lateral and
Same
placing the
position, you have to be in subcostal window, just turn the patient other side and put your long axis probe into the right axillary region. Try to look at an IVC and then IVC will tell you here is your good job. Give me a second. I'll show you again.
Okay, sir.
How to work? Look, this is my subcostal window over here. So I'm right over here.
Yes, sir.
And
Okay.
hepatic vein will drain like this.
Okay.
I'm just going to put my probe over here and then focus my image in the sense first. I'll try to look. These are all what are you seeing is portal veins. They are not hepatic veins.
Okay, sir.
They are portal veins. Correct. So we are not bothered about them. So I'm going to look at what? I'm going to look at my heart first. Reduce my depth. I'm going to look at my heart first. Where the heart shows presence of an IVC, I'll be using that. Now it's showing you. Look. Just appeared for a second. And this is where yeah, it will be very good seen when you have a large IVCs. Now you can see this. This is
Yes,
your
sir.
cardiac shadow, and this is hepatic veins, and there is your IVC. Now I'm trying to open my IVC completely. Here is my IVC. It's almost collapsed. Like sometimes we can't find obese patient subcostal window. You can use this window. That's what it means by. All
Okay,
right.
sir. Yes, sir.
Dr. Tushar Agrawal. Go ahead, Tushar.
Sir, from when we go from one view to other in 2D, in that, like every time we have to adjust this gain, like this dark and light thing.
Every time we call them as a grayscale. So
Okay.
plaques window will have a different grayscale. Apical window will have a different grayscale.
Okay, sir. Thank you.
Dr. Kamal, 21.
Ji sir. Sir, is there any difference between LVOT flow and aortic flow?
Yes. LVOT flow is before the aortic valve.
Ji.
Aortic flow is distal to the aortic valve.
Okay, sir.
Dr. Arya, roll number 2.
Sir, my question is, sir, how to adjust the grayscale? And the one thing is, you told in the WhatsApp group that American convention is the LV and LA is in the right side of our screen, but actually it is on the left side. But how you have adjusted that V
I'll
in
just show
the
you. Just look at it. Good, you remember the question. If you look at the screen over here, this is V, correct? This
Yes,
is
sir.
kept on right hand side of the screen. This is aorta, LA, LV, correct? Now I'll go from left to right. Let me see where it is. Now what exactly happened? Look at my V sign. Where is the V sign gone? Opposite side. This should have been over here. So I jolly well know, look, I'm doing on other side. That's one point. Same patient, I go to apical window, correct? The V victory sign is the right hand side of the screen. Now I can change this victory sign. This is what Mayo Clinic teaching is. But their V would be on the other side. So I'll go back to V and now rotate my probe in such a fashion that I am in Mayo Clinic recordings. My index marker, which was at 3 o'clock position, now my index marker has come to 9 o'clock position. So I'll be rotating clockwise. There I'm rotating counterclockwise. Look, I'm rotating clockwise. Don't get confused out of this. Just remember this simple formula. Your victory sign is always on your right side, and the LV is just below the victory sign. उल्टी डायरेक्शन में गाड़ी नहीं चलानी है, सीधी डायरेक्शन में चलानी है। और फिर चलानी है तो सीधी क्यों चला, उल्टी क्यों चलानी है? तो बिल्कुल ही उल्टा चलो। You'll feel happy in this position? No. Look, everything is so physiological now. My transducer is over here. My LV is over here. My RV is over here. My LA is over here. My RA is over here. My aorta is over here. It's so natural, which I'm doing it. Look at the screen. If my heart is over here, the first structure I see is LV, then LA, RV, RA, and aorta arises from here. So very natural. In fact, our teaching should be in this fashion rather than the upside down position fashion.
Yes, and how to adjust the grayscale in every view? What is the
Okay.
adjustment we should
How
do?
do you adjust the grayscales? Let me just show you how to adjust the grayscale. Now, look, there is two knobs over here. One is active mode, second is 2D mode. Correct? So I'm increasing the gain 2D modes. Reduce it, optimize your gain scales. Now your scale on this side is little higher. So there's a word which is known as trans gain compensation, TGCs. So I'm upper gains I'm reducing by this. Now I'm making my image little better. No, it's not working. Offline it's not working. Let me just show you online. Now your gains are a little higher on this side. So I'm just show Sigal. I'm reducing my TGC gains. Look, I've reduced my TGC gain over here. And in the bottom, the gains are a little high. I'm reducing the bottom gains. So these are segmental, you can say, gains reduction. Now reduce all the gains, the images disappear. Now increase the gains, all gains. You normally keep them in the center with the like this C-shaped pattern. So I can increase any one at my choice. Now I'm increasing the proximal one or the upper one. So this is how you can increase. This is overall gains. Look, I'm increasing the overall gains. Correct?
Yes, sir.
Play with the machine. That's the only answer you have. As you play with your mobile, play with your machines. Dr. Chaurasia and then Dr. Kailash Motera. Go ahead, Dr. Chaurasia. Dr. Kailash.
Hello, sir. Sir, in the suprasternal view, you said when we focus towards 1 o'clock, we can see almost the descending artery, descending aorta.
Correct.
Can we also focus on the arch, sir?
100%. Look, it's very simple. Look at the screen out here.
Yes.
My aorta arises from here, goes up, then dip posteriorly. Correct?
Yes, sir.
So if I keep my transducer at 1 o'clock position like this, I'm going to get my what? Descending aorta.
Descending aorta.
This patient, I'm not able to see a very good descending aorta. I'm getting a good descending aorta. So I can see a colors.
Yes.
So this is descending aorta.
Yes.
Now look at my probe. Keep on looking at the screen. Now moving this probe slightly, footprint slightly rightly, I'm able to get ascending aorta. So here is ascending aorta, red in color. And now in the meanwhile, I'm seeing the arch. From ascending to descending, here is the arch. This is all the arches. And we
Yes.
can see all the three branches of the arch of aorta. Let me try if I can get on this. Now this is ascending aorta. It should be red in color. No, not yet. And now you can see a red in color.
Yes, sir. Flowing towards.
Now, look, I'm just manipulating my probe. This is arch, and now descending aorta. They are in the almost same plane. Only thing is posteriorly got down posterior. And this this helps me very well, like looking at the ascending arch and the descending aorta. And now look carefully. I can see two arteries over here.
Yes.
One blue. This
Going
is
down.
left common carotid. This is subclavian. Subclavian will go like this. Left common carotid will go like this. Innominate will go like this.
Yes.
All right.
Thank you, sir.
Sir, Devangna here.
Devangna, just a minute. Go ahead, Devangna.
Sir, nothing. I just like to thank our volunteer who has, and when I say this on behalf of all of us, I suppose, who has so patiently helped us know so much.
Thank you, Devangna. I'll tell him. इनको सब धन्यवाद कर रहे हैं. Late नहीं के. All right.
And thank
Dr.
you, sir.
Dr. Chandra, roll number 37.
Good evening, sir. Sir, this
Good
is
evening.
Dr. Chandrahas Patidar.
Yeah.
Sir, I want to know in subcostal view, you made in subcostal view showed us all the four chambers, and by rotating counterclockwise, you showed IVC also.
Correct.
But sir, can we get other structures like other views from the subcostal window, like plex, like when we make plex view? Can we also get from subcostal that angle?
You can get everything from everywhere.
Okay.
Now here is a plex view. I can show you everything from subcostal window. Don't worry about it. But at your
Okay.
level, please not get into it. Let's remember the normal views. So this is my four chamber view.
Yes, sir.
Correct. So if I open up my aorta over here, somewhere here the aorta will open up. I can rotate this and get my aorta opened up. Now see the aorta is opened up already. So this becomes my LV. This becomes my aorta. Here becomes my LA. Here is my RA. Here is my RV.
Okay.
And this is how we do it number of times when we do not have a good windows. Lamba सांस लो, लेके रोको. Now I'm going to make short axis view. Parasol short axis view of aorta. छोड़ दो सांस. फिर से लंबा सांस खींचो. जोर लगा के. Good. छोड़ो. ज्यादा ले लिया. छोड़ो. और छोड़ो. Yeah. Now you can see everything out here in one view. This is IVC. Here is RA, tricuspid valve, RV, RVOT, aorta in the center, interatrial septum. This is LA, and here is a pulmonic artery.
Okay, sir.
So it all depends, what we teach is a conventional views, but we have thousands of views before than that. Okay?
Okay, sir.
Dr. Kamal Malviya, 21.
Yes, sir. Sir, can you please repeat how to set up the Nyquist limit, and why do we set this Nyquist limit? What is the significance of it?
Significance of this Nyquist limit is what I'll just show you what is the Nyquist limit. I'm switching on colors,
Yes,
Now I'm going to optimize color. I'm going to increase my colors. Now you can see a lot of garbage.
yes, sir.
I'm going to reduce this garbage. So I've used this button, active button. You can show me. See this active button over here? There is one active mode. This is 2D mode. So in
Okay,
active mode, I'm increasing my gains. So I'm
okay,
reducing to make it so the garbage disappear first. Then second on top of the right hand side of the screen, you see this Nyquist limit 66. So I'm going to
okay,
reduce this Nyquist limit to 56 on either side. This is 56, this is 56. It
okay,
means that after 56 centimeters of the blood flow velocity, the color will change from yellow to green on other side. Okay. Now I'm going to reduce this Nyquist limit further. Now look what exactly happened to my colors.
Mhm.
This Nyquist limit is 19 now. And look at the colors over here. This color 19 will convert to green color at the Nyquist limit of 19 centimeters to give you a flow. Now look, it's all haphazard to look like. So this Nyquist limit is capped at between 50 to 60 to get the best color flow pattern. Now you can see the color flow pattern in this patient now.
Yes, sir.
Versus the color flow pattern in this. Second
Okay,
important thing is when we use this Nyquist limit during PISA method and other things, we change this Nyquist limits towards the flow of a direction. Now I've gone up 33, bottom 61. So this is what is at what velocity it will change its flow velocity with this kind of a things, that is Nyquist limits. Remember this, we keep a Nyquist limit between 50 to 60. At what point the aliasing starts happening.
okay.
All right.
Thank you.
Dr. Gaurav Singh, go ahead.
Uh, Sir, in apical view and sometime in apical view, sometimes, sir, apex is not visible. The
Good
top
question.
limit of apex, and in plaques view, sometimes, sir, RV is not visible. Only we see the IV, this septum. The view starts only from the septum. So how we should maneuver so that a
Let's look
good
at an
image?
apical window
Yes.
first. For apical window, like look at this is your apical window. You say your apex is not visible, correct? This is
Yes,
not
sir.
visible. So answer is go a space down. Instead of 5th intercostal space, go to 6th intercostal space. Now nothing is visible except the image. Ask the patient to take a deep breath. Lamba सांस लो. Look at your apex. Why the apex
Okay.
is not visible? You are in 4th intercostal space. Now if you go space down, ask the patient to take a deep breath, your apex will become visible. छोड़ दो सांस. लंबा सांस लो. This is true 4-chamber view.
Yes, sir.
Now the same thing in Plaque's window. When you can't see a Plaque's window properly, you have to go. Look, this is where you are all the times. All the times we will be in 4th, 3rd intercostal space. Here. This is not a Plaque's window. The Plaque's window is when aorta is horizontal. And we only see basal anterior septum and basal posterior wall. You should see only basal anterior septum, basal posterior wall. Not this one. This is apical long axis view. We should see only this just close to sternum. And look here, both leaflets, right cornicus and non-cornicus, are equally opening.
Okay, sir.
So I think that is what we need to understand as far as Doppler is concerned, because this is the backbone of our whole teaching. I know this is the toughest thing to understand, but if you can't understand all this, there will not be anything else which is possible. Okay?
Yes.
So what we are going to do is we'll keep one more session for this live demonstration after 2 weeks. And meanwhile, we'll send you all the recordings so that you can digest whatever we have taught to you today. And you can really look at all these things in total. So I'll stop over here. Don't go away anywhere. Just stop over here.